And it's my great pleasure to introduce Dr. Zimmerman, who is going to talk today about a very interesting and important topic, which is the global burden of congenital heart disease. So, Meghan, thank you very much for joining us today, and the floor is yours.
Thank you so much, and thanks to all the organizers who helped make this happen. I'm happy to be a part of the ongoing work that you guys are doing in this collaboration. So as I just mentioned, I'm going to be talking about the global burden of congenital heart disease. I was asked to speak on this topic because I have a bit of background in working with the global burden of disease data, and I'll go through what that is from the Institute of Health Metrics and Evaluation, the IHME, which some of you may be familiar with. I am currently a practicing cardiologist in pediatrics at the Children's Hospital at Dartmouth, and that's in New Hampshire, which for anyone not familiar with that area is just north of New York City in New England in the US. So in terms of disclosures, I don't have any specific disclosures at this time. I did want to mention that I don't have any formal affiliation with the Institute of Health Metrics and Evaluation. I have been a collaborator with them, but I don't have any formal appointment with them, but I am going to be talking about a lot of their data. Oh, and another disclosure is just to say that I'm not an adult congenital heart disease specialist, so I am a general pediatric cardiologist. So just to keep that in mind as I go through some of the data as well. Here are the learning objectives that were also, I believe, sent out to you guys through the announcement for the talk. So briefly, we're going to review some of the currently available data on the burden of congenital heart disease worldwide. And then I'll do a little bit of focus on the adult congenital data as well. My other goal would be to help everyone understand some of the methodology and the limitations behind the global burden of disease data, as I mentioned from the IHME. And then I'm going to spend a little bit of time at the end just showing everybody how to find some of the publicly available GBD data and use the visualization tools that they have available if that's something people are interested in, because I think it can be really valuable. So to start with, in terms of just reviewing a little bit of the history of the burden of congenital heart disease and what's actually out there right now, if you look at any sort of website looking for what is the, congenital heart disease burden, what is the prevalence number, you'll see on similar sites like the CDC, there's this rate of about 1%, as we're all familiar with, about 1 in 100 babies are born with congenital heart disease. And so if you look at the citations of where that comes from, so I don't know if you guys can see my mouse here, but the superscript of 1 and 2 citations are almost always referring to these two papers. So the first paper is by Hoffman and Kaplan, and that was put out in 2002. And the second one is by Reller and Strickland and colleagues, and that was from 2008. And they're both, I'll review a little bit of detail in them, but they're both the most commonly cited references for talking about the baseline prevalence of congenital heart disease. So the Hoffman-Kaplan paper was a review of 62 studies from the 1950s up into the early thousands. And it was really mostly including, if you look at the citations themselves, it's mostly data from national studies. And most of them were actually from high-income countries. The estimate that they gave overall for that entire time frame was about 6 per 1,000 or 0.6 per 100. And then one of the things the paper really brought up was the difference of whether or not you include small ventricular septal defects in that estimate, and that would really raise the overall prevalence to about 7.5 per 1,000. They did make a note too that prior to the use of echo, the estimates were lower, which makes sense. We weren't picking up a lot of these smaller defects, so the rates were more like 4 to 5 per 1,000. And then as we get into the later years of using echo, those rates increased to really the numbers that we use more now in the 10 to 12 per 1,000. And then of course, if you include something like bicuspid aortic valves, the rates increase almost double, as we know that the rates of the bicuspid aortic valve are about 1 to 2% in the population. And then the Reller paper was actually from US data from the Metropolitan Atlanta Congenital Defects Program. And this was pulling data from 1998 to 2005. And this is an ongoing active surveillance program in the metropolitan area of Atlanta, Georgia, which is in the southeast of the US. And they quoted a prevalence of about 8.2 per thousand live births, so similar to the prior paper. And then these two I wanted to pull in as well. These are two of the more recent studies that sort of redid the analysis and looked at what is the true birth prevalence of congenital heart disease. So the first is a paper by Vanderlinde et al., and the second one is by Liu et al., and I'll just briefly review these as well. So the Vanderlinde paper, again, was a systematic review of 114 papers, nearly 25 million live births, 160,000 patients with congenital heart disease. And they calculated the birth prevalence to be about 1.3 million births with CHD each year. And this equated to about 9.1 per thousand after 1995. And if, again, you look back over time, that was a steady increase from the 1930s, where it was quoted to be much lower, about 0.6 per thousand on the original detection. They did also report some regional differences across the world, in that Asia had reported a much higher prevalence of about 9.3 per thousand compared to North America, which was quoting more of like a 6.9 per thousand rate. And then the most recent paper put out in 2019 was, again, a systematic review and meta-analysis of almost all the studies that were done between the 1970s and 2017. So 260 studies, again, showed a birth prevalence of very similar numbers, about 9.4 per thousand. And interestingly, this paper included a analysis of why and what accounted for the increase over time. So as I mentioned in the prior papers, they looked at prevalence steadily increasing over time, and really what's fairly intuitive, but they explained, is that nearly all of that increase can be explained by the mild congenital heart disease lesions, so things like VSDs, ASDs, and PDAs that were now included in those estimates. Interestingly, they also put in some information about left ventricular outflow tract obstructive lesions, so things like hypoplast, coarctations, aortic atresia, those types of things, and mentioned that the prevalence rate for those lesions had decreased from the 90s into the second decade of the 21st century, and noted to be likely due to prenatal detection and termination of pregnancy. Again, they noted the regional variability. This systematic review actually did include 2 studies from Africa, which had a very discrepant rate and quoted a much lower prevalence of about 1.3 per thousand compared to, again, the rates from Asia, which were the highest, about 9.3 per thousand. So turning to the global burden of disease study, this is, I'll go through a little bit of history of it for people that aren't familiar with it. So this is sort of the new wave of how to get estimates of congenital heart disease burden and other disease burdens when there isn't data, and trying to look at things worldwide. So to start with, just a little bit of history, really the GBD, the Global Burden of Disease, the idea of it was commissioned first by the World Bank back in 1993. And the original study was published on about 100 diseases in the World Development Report. So this was supposed to be, this is really the beginning of trying to report on diseases worldwide. In 1998, the WHO created more of a specific unit to continue working on this, and they had increased to about 136 diseases at that time. And then in 2010 they got more funding from Bill and Melinda Gates Foundation, and were able to expand this to a lot of global experts and many more disease processes, almost up to 300 at that time. In 2013 is when the Institute of Health Metrics and Evaluation, the IHME, is kind of born out of the University of Washington, and that becomes the coordinating center for GBD. And then in 2015 is when they start publishing some of the annual reports that many of you have seen, I'm sure, in the Lancet. And they're called the Global Burden of Disease, Injuries, and Risk Factors Study, otherwise known as the GBD studies. The most recent data is from 2019, and here is a snapshot of the most recent issue. So again, this is a dedicated publication for the GBD data, and that was it was actually published in October of 2020 for the 2019 data. If you look at the exact numbers from the 2019 data, this included more than 5,000 collaborators from more than 150 countries across the world. There were nearly 370 diseases and injuries reported on and included 87 risk factors. And every year they increase the number of countries and territories that they're able to report on. So this past publication included 204 countries. And you can break them down, and I'll show you this at the end as well, but it can be broken down by what they call the GBD super regions or custom regions like the World Bank regions. And then the most recent improvement is that there's now a lot of subnational data for countries that have more subnational data, really. And so when you look at some of the maps, you're able to see within each country it broken down into subregions as well, so it's much more specific. And this is updated with every iteration of GBD. The measures that are utilized and can be used within the GBD data includes things like death and prevalence, but also includes things like disability, so disability adjusted life years or DALYs. You can also look at the maternal mortality rate and other types of measures. I wanted to briefly talk about the data sources. So this is a little bit about the methodology behind GBD for anyone not familiar with it. You know, I'm not an expert in this, but I have done a little bit of training with IHME when I was working on our publication to understand it. So I have a brief knowledge on it that I'll share with you. The mortality rates specifically, if you're looking at mortality data, it mostly comes from vital registration data whenever there is data available. Whenever you're in a country or region when there is no data available, this really relies on census data and then verbal autopsy surveys to account for trying to predict what the mortality rates are in that region. And then when looking at the cause of death, so really trying to identify causes of death in a certain area, these again rely mostly on ICD-9 codes or other classification systems that are coding what the cause of death truly was. There is something called redistribution of coding. So if you think about within ICD codes, for instance, what I'm most familiar with, there are lots of codes that say, you know, non-specific heart disease or something, or heart disease otherwise unspecified. And so those codes are taken and basically redistributed into other types of more specific heart disease based on known percentages and classifications in that area. So they're able to kind of redistribute them so that they can be used more in more clarity. And then there's something called Codem, which is cause of death ensemble modeling. And this is a very intricate tool that's used to basically create models to come up with a cause of death based on other covariates when you don't have any data on cause of death in a region. So the idea is that you take covariates that you and I probably wouldn't think would be related to something like congenital heart disease and put it into a model and run it multiple times and see that it matches the cause of death in an area that's similar to the area that you're looking at, and try to come up with a sense of you know, percent cause of death or rates of death from congenital heart disease in that region. So just as an example, this is the Codem for congenital heart disease that we used in our last publication for 2017. So the covariates include things like alcohol consumption, sociodemographic index, smoking, diabetes, and other things you'll see listed there. And then the model basically determines how either positive or negative the association is with this covariate and congenital heart disease as the cause of death, and is run, you know, multiple times in different ways to create a model that fits, and then again is applied from a region that has a similar demographic to the region that you're interested in to try to come up with that. Hopefully I explained that okay. If we have more questions at the end, I'm happy to try to answer them as well. And then so that was the data sources for the fatal or mortality data. And then in terms of the non-fatal data, this includes things like prevalence, incidence, disability adjusted life years. And so this data is pulled from systematic reviews of published literature. So for instance, for the congenital heart disease paper we put out last year, it included a review of more than 2,000 abstracts and titles that were initially screened and did a full review of 88 different texts, and then 27 were extracted to pull data specifically from that to incorporate into the estimates for things like prevalence of congenital heart disease. It also incorporates in survey data and administrative records. So administrative records is anything from health encounters like hospital admissions, outpatient visits, insurance claims, and then also includes registries from across the world. As I've listed here, these are the ones that were included in the congenital heart disease paper. And then the last thing is any disease surveillance systems that exist to track that. So like the Metropolitan Atlanta birth study as well. This map shows the data availability across the world. And so the green countries or regions are the areas where there is data on both fatal and non-fatal cases. The purple is where there is data only on fatal cases, so really only mortality data. And then the orange is data on only non-fatal cases, so they only have data on things like prevalence and incidence. And then the yellow is where you can see that there's really no data, no raw data or limited raw data to be pulled for evaluation in the GBD study. And so this really includes most of Africa and a lot of Southeast Asia as well. This was the paper I've mentioned, so this was really how I got involved in a lot of this, actually starting way back in about 2015. In my training, I was asked to help I was one of the writers for this paper. And so with a lot of collaborators, we wrote the first congenital heart disease GBD paper with all the data that they had on congenital heart disease, because that hadn't been put out there yet. As you probably all know, it takes a long time with some of these big collaborative papers to get out, so it really didn't get published until this past year in 2020. But this included data from the 2017 iteration of GBD data. So what did we find? In terms of looking at the estimates, the birth prevalence that we actually determined based on GBD data was a bit higher than prior estimates, as I mentioned before. So the estimates were about 1.8 per thousand live births had evidence of congenital heart disease, and that did vary depending on what region you were looking at. So this SDI region is socio-demographic index, so referring to basically income levels within certain countries. So in the lowest income regions, the rates were more about 25 per thousand, and in the highest regions, it was about 12 per thousand. And this 12 per thousand reflects much more in line with the data that, like I mentioned before, what I presented is more in line with the prior studies showing us a rate of about 1% of CHD in the population. The prevalence overall was estimated to be 12 million people living with CHD worldwide, and this was a decrease in about 18%, an increase from about 18% from 1990. Not surprisingly, as we know that many of our adult patients with congenital heart disease are living longer. The number of deaths attributable to CHD was about 260,000, and this was, so these are annual deaths, and this is a decrease from 1990 of about over 30%. So also showing a considerable change over time in the death rates from congenital heart disease. And then I like to throw this in there too, because I'll show you certain ways of modeling it and displaying this data, but you can look at leading causes of death depending on age group. And so we found that congenital heart disease was the 6th leading cause of infant mortality globally. And when you look at the higher SDI countries, it actually increases to the 2nd leading cause of death. I also pulled some numbers from the most recent data. So this was actually comparing 1990 to 2019. This is the most recent data available through GBD. And you can see this is the prevalence number written out, and then the prevalence rate, which is per 100,000, and then the 95% confidence intervals for those. On the left-hand column, this is broken down by age group, and then in the other 2 columns, it's broken down by the year. So I'll just point out that the prevalence number, the total number of prevalent cases, has gone up in all age groups, not surprisingly over time, and obviously the population has continued to increase. But you can see this dramatic increase in the number of 55 plus people who are greater than 55 with CHD increasing dramatically over the last 30 years. And the the prevalence rate itself hasn't changed significantly, but it did go up in this age group. So from 83 to 89 per 100,000. And then looking at all ages, again, you see the prevalence number go up. The rate of CHD actually went down a little bit, and that's mostly due to an overall aging population across the globe. So as more people continue to live longer in general, then that prevalence rate actually goes down a little bit. This is the same table, but looking at number of deaths and the death rate per 100,000, and again with the same age groups. So you can see that the death rate overall from 1990 to 2019 has dropped dramatically over these 30 years in the youngest age group, so the under 5 population and the adolescent and early adult years. And then as you can see in the older age groups, the 20 to 50 and the 55 plus group, the rates have also decreased, but the sheer number of deaths has gone up, and that's probably just because we have more patients living later, and then they're dying later in life. But again, overall, with all ages, you can see the dramatic decrease in the death rate from 7.1 to 2.8 per 100,000 over 30 years. So this is a big success story overall. To touch specifically on some of the adult congenital heart disease data and the burden of heart disease in this age group, since this is what I know everybody is more interested in, I just wanted to pull a couple of the studies that have attempted to give these numbers, the prevalence numbers of adult congenital heart disease. So one of the more recent ones from 2012 by Vanderbaum and al. Was a systematic review of 10 publications. And as you can see, there's 10 publications compared to our prevalence data for all congenital heart disease, which includes things like 260 publications. So much fewer publications out there on ACHD numbers. And they quoted a prevalence of about 2.3 to 3.5 per thousand. And this varied depending on how many of those non-specific lesions are actually included in those estimates. And then this paper actually did a specific calculation for the Netherlands based on population, and this gave a prevalence of about 3.2 per thousand. Another study that came out in 2014 is by a group out of Quebec by Morelli and al. And this was looking at the lifetime prevalence of congenital heart disease in the early 2000s using a registry that is a 28-year registry in Quebec City in Canada that tracks everybody with congenital heart disease, which many of you are probably more familiar with than I am. And what they found was that the prevalence for adults living in 2010 in Quebec was about 6 per thousand for all congenital heart disease lesions. Their study also broke it down by severe lesions and non-severe lesions, and obviously you can see that with severe lesions, the prevalence rates are on an order of 10-fold lower in terms of survival into adult age. And then a couple of years after that, the group from the US actually basically did the same thing took the data from the registry in Quebec and applied it to the US population to get estimates of the adult congenital heart disease burden in the US. And similarly, they found that the estimated prevalence of overall CHD in adults was about 6 per thousand. And that turned out to a rate of about, or a number of about 1.5 million currently living in the US with congenital heart disease. The overall rates, if you add those up for both the children and adults living with CHD, was about 2.5 million total. So if you compare this to the GBD data, and many of you may have seen this already, the 20 plus years of age group that I can pull from the registry, right, or that from the GBD site right now actually really only quotes about 5 million people living with CHD globally. And the rates are much lower than what I just quoted in those papers. So the rates of adult congenital heart disease worldwide using GBD data is quoted to be about 0.9 to 1 per thousand. And that's in the high middle SDI regions, and it's even lower in the low SDI regions of about 0.7 to 9. So there's a big difference in terms of the estimated rates here compared to the studies that we usually refer to. And then if you specifically look at the US ACHD prevalence in 20+ year age group, this is down to about 200,000. So way different than the 1.5 million that was quoted in the other study. And so the question is, why is this so different? So there are lots of reasons why estimates can be so discrepant. And specifically for the GBD data, I wanted to point out that there is some modeling that has been added in that allows for spontaneous, so it allows for regression of disease, including spontaneous closure and then what we call a natural regression after repair. So it accounts for spontaneous closure of small VSDs and ASDs, and then also allows for some regression of a simple repair for mild lesions that may not even be followed anymore as truly CHD. So something like a PDA that's been closed and not even really counted as a patient with CHD anymore. The classification of CHD obviously will vary the rates as well. So depending on what types of lesions are included in the studies will make the prevalence rates of CHD very different, as I mentioned before with the Hoffman paper. Whether or not you include small ASDs, PDAs, and other things in the calculations will alter those rates pretty heavily. And then the other big thing that changes these rates are the allowance for multiple defects. So if a patient has multiple congenital heart disease defects, do you just count that as one CHD lesion and use the most prominent or severe defect, or do you include all the defects and count those as separate encounters? So that can also alter, depending on how you're coding and how you're pulling rates, can alter the prevalence rates a lot. I did want to mention, though, there have been some advances over time, even though there's still some great limitations in the data. Some of the advances that have changed over the iterations. Since 2016, the survival estimates, especially for the neonatal group, has improved greatly. The most recent GBD estimates use multiple things like screening programs, congenital registries, administrative data, and other data sources on those survival rates. Compared to the prior iterations of GBD, we're actually modeling them based purely on neonatal mortality. And so that's been a huge improvement in estimates of neonatal deaths. The remission modeling I mentioned, so this was added in just within the last 5 years as well. So it does allow for natural remission of certain lesions, as I mentioned before. And then third, as we all are aware, there are many CHD lesions that are associated with genetic syndromes, and prior iterations of GBD did not allow for simultaneous diagnosis of a genetic syndrome and CHD. It only had prevalence counted for one of those, so now it allows for both. So that's also a huge improvement. So a patient with trisomy 21, also with a canal defect, would be counted for both. And just to highlight the fact that this data, while not perfect and has many limitations, has had a huge impact on the ability for regions and countries to come up with more health policy and priority agenda setting based on the data that is now being put out there. For instance, I mentioned this neglected or uncovering hidden diseases. Some of the data that we've looked at and used for rheumatic heart disease has really uncovered and helped demonstrate the need in certain areas for continued work and treatment and programs for rheumatic heart disease in areas that may not have otherwise been noted before because there weren't data. So it's providing estimates of disease burden in places where there isn't data. So it can be really powerful for things like health policy and fundraising and things like that. These are the two websites for people that aren't familiar with it, and I'll show these at the end if we have a little bit of time for it, of how to find the publicly available data and then how to create visualization tools for use in either teaching or research or other things. I think they can be pretty powerful to show, and I'll give you a couple examples of those now, and then I'll show you the website. So this is just a generic map, which you can kind of create your own maps of prevalence or death data. This is the neonatal CHD prevalence, from 2019. As I mentioned before, we now have subnational data within GBD. So if you look within some of the countries like the US, you can see that there's now state level data. And this is showing that there's a significant difference if you look at the neonatal prevalence of CHD in certain regions. The dots down here are aligning with the lowest CHD prevalence and the highest CHD prevalence in red. And there's quite a few outliers over here. And it lines up, if you notice the map in Southeast Asia and in Africa, where we have the least amount of data, is the kind of greatest outliers. So that the highest prevalence rates are quoted in those areas. So some of that is just based on the estimates and the limitations we have with those. And some of it may also be due to the fact that there's a much lower life expectancy in some of those regions. So the prevalence of CHD may end up reflecting as a higher percent based on the average age of population. If you change the map to, instead of neonatal prevalence, this is adult congenital heart disease prevalence. So between the ages of about 16 and 50, you can see the map changes quite a bit. And again, the blue is the lower rates and the red is the higher rates. So you can see the highest rates are in some of the highest income regions, and the blue is a little bit more located in some of the lower income countries as well. So you can kind of play around with this and try to find differences in regions using this tool. In this one, I actually did cut off the last couple outliers because there were 5 or 6 up here that made the graph or the map look like it was all one color. So you can also play around with taking out some of the outliers and focusing in on the ones that have more data. This is an example of just a graphical trend that you can pull from the website as well. This is deaths per 100,000 from CHD, and along the x-axis is the year from 1990 to 2017, and each color is representing a different sociodemographic index region. The lowest one here is the high income regions. Not surprisingly, the death rate is very low compared to the other regions. And then you can see a fall over time of a decreasing death rate for most places, except in the low SDI region here in the dark green. That one has stayed pretty steady and unchanged, unfortunately, over time. Another way to look at data is using something called a heat map. So in this example, you see different congenital lesions on the left side. So these are congenital malformations, and congenital heart disease is at the top as the #1 cause of, this is disability adjusted life years. So these are DALYs worldwide and through all different SDI regions across the top here. You'll see other congenital heart disease, you'll see neural tube defects. Down here you can see Down syndrome. And again, this kind of gives you a sense of where things rank in terms of the cause of either death or disability or other things. And one more example, this is an arrow diagram, and you can basically take whatever cause you're looking at. So if you're looking at what is the cause of death, this is the under 5 age group, and you look at the 1990 data and the 2019 data, you can see how things change over time. So these are all in blue because they are the non-communicable diseases, but you can also add in things like communicable diseases or injuries and see how things have changed over time. So not totally surprisingly, you can see that in the under 5 population, congenital heart disease is still ranked #1 in terms of cause of death in this under 5 age group. And then there are some things that have fallen over time, like death from leukemia or asthma has dropped significantly. And you'll see this even more dramatic if you look at the communicable diseases over time. So as we've gotten better at treating infectious etiologies worldwide, the communicable diseases have dropped and the non-communicable diseases have gone up in rank in terms of the cause of death. So this is the homepage for IHME, and I'm just gonna switch over real quick in the last 5 minutes before we do some time for questions and show you guys a little bit. If the website doesn't work, I'll just show you in PowerPoint form. But for anyone that's interested, you can become a collaborator. And again, I don't have a formal affiliation, so I really like the data, I like the group, and it's really nice to work with people who know a lot about modeling and data. The other thing I'll mention too is that they are continuing to work on improving their data modeling, and they're very open to working with collaborators to make the CHD data and rheumatic heart disease and whatever other heart disease you're involved in improved over time. So just wanted to put that out there. So again, this is the homepage. If you're looking for raw data to pull to, look for specific rates, you go to this results tab and go to the GBD results tool. And this will take you to a page that looks like this. See if it loads. So for anyone that isn't familiar with this page before, basically you can just choose from a list of a lot of different locations, either country specific, region specific, or you can use some of the larger regions like the SDI regions. At the bottom there are the World Bank and WHO regions you can use if you want to break it down that way. The year you're looking for, the age metric, which they have added a lot of different age groups over the years. So now there's more availability for looking at things like the adult congenital heart disease group, different metrics, and then the measures I mentioned before. So these are either looking at death, prevalence, incidence, those kind of things. And then the cause of death you would put in here, which is, you can really just type in congenital and find congenital heart anomalies and search based on this. And the nice part is that you can either just search on the page here and it'll spit out the numbers down here for the values you're looking for with the confidence intervals. You can create a link to it, so it'll give you a link that you can copy and then go back to or paste somewhere. And then you can also just download the raw data and it'll give you an Excel file of the data that you can use and manipulate yourself. So that's the results tool itself. There's lots of tabs in here for help if needed with some of the data. And then the other two I wanted to show you real quick, if you go up to this GHDX tab in the top, you can see that this is the Global Health Data Exchange. And if you want to search a certain, cause of death or a certain disease process, you search here and then you can put in the country of interest here. And this will basically give you all of the available data that they have in their catalog for that diagnosis in that region. So it would be things, as it mentioned up here, so things like surveys, census data, statistics, publications, everything that they use in their estimates, it'll give you the links to. So if you just put in like congenital heart, let's see if it runs a search, it might be too big. It gives you 6,000 items within the current search, and then you can kind of search through and look for what you're looking for specifically, and then you can sort it as well. And then lastly, this GBD compare tool, I'll just show real quick. This again is how you can pull data visualization tools, and how I created some of the ones in the PowerPoint that I showed. So this is the home page for the visualization hub. And on the left-hand side is all different types of visualization tools, from the maps to the arrow diagrams to heat maps and patterns. And so you can play around with this and either do what we call single data, or you can actually do, you can do comparison if you want to compare two different age groups or two different locations. And you can play around with the age group and the cause and all that stuff. So it gives you a lot of ways to visualize data that are really helpful and fun and color coded. And then if you ever want to actually download it, so you don't have to just copy it, you hit this download button and go to screenshot, and it'll take a screenshot and save it to your computer, so you have that. You can also download the raw data from here as well. So that is a bit of a whirlwind tour. And I will just pull this back up so you guys have my contact information, and there's my email if anybody wants to contact me with questions. And then I think I left 15 minutes so we can do some discussion time.
So thank you very much for such an interesting talk and very interesting data. So if anybody has any questions, you either can type it on the chat or unmute your microphones and ask the question. So while people think about questions, I'm sure they will have many. It's clear that that the data show that we must be doing something good because the patients are getting older, and definitely the numbers are impressive. And one question I have, you said in one of the data that you use is health encounters as part of the data. How do you get that data? So because I guess that the health encounters is something that you have to request, so the countries give you the data to the database. How do you get that particular data?
Yeah, I don't know if I can speak to the exact answer. So IHME has worked with countries over time to pull as much data as possible from their regions. And every country is a little bit different in how available the data is. A lot of the health encounter data, I think, comes from certain registries that people keep, or if they have regional areas that have better health systems that track over time, they're able to get that more easily. But it's really just availability of certain regions and certain countries that offer that as an option versus not. So it's pretty variable in terms of where it comes from. I think the hospital admission and discharge data and the health claims data is much more readily available.
Mm-hmm. I guess that the data that the GVD just negotiate directly with the countries, or because I guess that this is of course not center related, it's just country related, right? So I guess that they must negotiate directly with the health authorities and to get the data, or is it just to understand a little bit how is the organization behind then getting the data? Because I think the data is very interesting, really extremely helpful. As you said, it's allowed to plan for the future in certain regions that might in not developing countries, but also in developing countries, and particularly in congenital heart disease, we can see that we're going to have something we are seeing already. When I have a problem with adult congenital heart disease, that when I have more patients, I'm going to probably need more resources. So I guess that their interaction is with the countries themselves to get the data, right? So that's
yeah, and I know that they've run in, every country is a little bit different, every region's a little bit different in how available they are willing to make things due to privacy laws and other barriers to just sharing the data. So it's been very country specific. And then the nice part is that they have collaborators in so many places that they're able to have those conversations and push for more data in areas where it's lacking. And so over time that has improved greatly. As I showed that the list of all the countries that have subnational data, that's really in the last 5 years that they've been able to get more specific data at the subnational, less lower than country level, and that's really helpful for huge countries, obviously, when there's a lot of variation. So I think it has a lot to do with their discussions with the governments and registry handlers and whoever is in charge of privacy laws, but it does take a lot of work in each country to get that data, for sure.
Thank you so much, Rafa. If you allow me, can I have a question? This is Dr. Norman.
Please go ahead.
Yeah, thank you so much, Dr. Meghan. I'm one of the old fellow from the Congenital Center in Toronto. First of all, I would like to thank you for sharing the data and sharing the sources as well, and for the marvelous talk. My question is that what is your suggestions and how can we improve, as the same question that Rafa just asked, regarding data sharing, especially from the third world countries or South Asians. And currently I'm based in Middle East, Riyadh, Saudi Arabia. The system here is relatively better as compared to the South Asian countries. They have a better database. But how can we improve further individually as well as in the government or institution level, so that the more data can be shared in the hub, so that it can be reflected? I'm sure many people, they are collecting the data, but the thing that cannot be reflected in the search engines, because excuse me, because it's not been properly shared and properly been uploaded to the relevant engines. So that's the reason it cannot be accessible to the international organizations or who are maintaining the data.
Yeah, it's a great question. I think there are a couple of things. I mean, one of the things is really to make sure that the data that's already generated, that exists, is being utilized by IHME. So that can be a simple contact to the IHME group, and making sure that, like, if you notice in an area that you're working in that it shows that there's not data, or that it's not reflecting the data that you're aware of, or say the prevalence rate is way different than what you're experiencing, then you can definitely be in contact directly with the group and say that you have this data and wanted to make sure that it is being utilized appropriately within their estimates. So we had done that with certain studies that were out of region of Uganda that we were working in, specifically for rheumatic heart disease and some of the congenital heart disease studies, to make sure that they had most up-to-date data. So it can be directly communicating with them to make sure they have it. And then the other piece, obviously, is that just continuing work in areas where there is very little data to try to come up with some estimates, which again is not an easy task, but creating things like registries to track certain diseases can be incredibly powerful. And trying, whatever ways possible that work in that region to have data systems that are available and be able to be utilized in this way is great. And we all struggle with that, even in our own places where we're working, to have good data systems.
So I just have another question. Sorry, go. Okay. So one of the things that you mentioned is that, but I actually was quite impressive, is the difference in prevalence between the data extrapolated from the Quebec database and which was extrapolated to the US, and the data that came from the GBD data. Mm-hmm. And so the Quebec database is actually is the Quebec province's every interaction with the health system is documented. And the data is every single patient that has an encounter in the health system is collected nationally, so regionally in the whole province, and that's the data where the data come from. So it's a quite robust prevalence, because it's not like volunteer. It's not a voluntary registry or anything. It's just it's health system data, and that's how that prevalence was extracted. And I think the US study just extrapolated that data. So my question is, so with that data seems quite robust in terms of numbers, and however it's like almost 6 times more than the one that you get from the GBD. My question is possible that the data that we have for the GBD is not as robust in terms of collecting all the patients, because many registries that you have around the world might be voluntary and might not collect. Just it's a reflection of what that could be a possibility. I just want your thoughts on it, because you know the data better than me. Whether it's a reflection that there are some countries where the registry might be voluntary and you might not have all the patients that have in that country or in that region or in that province. So I don't know if that could be a possibility. I just don't understand really well how these data get on the GBD.
Yeah, I think for a data set like the one in Quebec, it's fairly, I think, clear that is really good raw data, like you mentioned, that it includes every single patient, and it's involuntary in a sense, so it includes everybody, and so it's pretty reliable. When the data from GBD incorporates that in, it's just one part of their estimates. And so, like you mentioned, there are so many other pieces they pull in that then create the estimates that it can alter the data in a way that may not reflect the exact numbers. And so, for places where there is really good data, it can almost be a hindrance, and alter it in a way that makes it maybe less reliable. As I showed the one, like the comparison for the US. And that's really because it's trying to incorporate all these other features, including, hospital encounter data and, outpatient data and that kind of thing. So it may dilute it down a little bit and not get as good of an estimate. So I think for regions where there's really good data and really good studies and registries like that, and great tracking, which we have in many countries, you could argue it's much better to use the raw data and what's available. Really, the GBD strengths come from trying to create estimates in places where there's very minimal of that, and you don't have that available. Does that help answer that question?
Oh yeah, of course. I think it's great. I think
Yeah.
it's just the truth is probably somewhere in the middle. I think that is not as high as we have in Quebec, which is just a single province, or as probably as low as the GBD data might show. But I think the truth is in the middle, and I think it's a great what the GBD is doing.
Yeah, so I agree with you. I think it might be somewhere in the middle. We don't have obviously the.
Well, but it's great to have an initiative that we are trying to achieve that. So I think it's a great initiative. So there's a question from Dr. Bravo said, thank you for the talk. So how can we ensure data quality in developing countries? For example, some countries do not have availability of screening programs or even echocardiography in most of the regions. And many children may be diagnosed with pneumonia instead of having to work out for congenital heart disease.
Yeah, it's a really great question. And I think we have only kind of the tools that we have so far. So I showed those couple studies out of Africa that were reported in the most recent 2019 publication on birth prevalence of CHD, and even those when they were trying to track CHD prevalence based on country-specific data were way lower than we see in other areas. So that birth prevalence rate was about 1.9 per thousand compared to the 10 to 12 we see in other regions. I think that is a known limitation, and it will be a difficulty for many places because it's hard to do echoes, or you may not have availability of doing echo screening in many areas, and diagnoses, like you said, could be mistaken for something else. And there are tons of neonatal deaths that occur worldwide that we don't have a specific cause for, so they're not necessarily coded correctly. So that is unfortunately always going to be a limitation. The idea of the GBD estimates for some of those areas is to try their best to replicate in any area where there is some known data and more accurate assessments of CHD burden. It tries to model those numbers in the areas where there isn't data. So it tries to apply it. But if you look at the confidence intervals in some of the areas, they're much greater, and the estimates have much more variability. So it's unfortunately not ever going to be. It's going to have those limitations, and I think that's part of understanding the data and knowing what you're working with, and you can present the numbers. And knowing that they have these wide estimates and that they may not be perfect, but that's sort of all we have to use.
Mm-hmm. I think that's one of the limitations of working with arrays tree like this, right? Where you have to take what you have to take, and probably what is probably the prevalence is, if anything, underestimated because of the countries that don't have access to data or a capability of collecting the data as good as other countries. We have time for one more question. So Dr. Osling asked a question that is, how is the GBD database fed with data? I think that you mentioned that. He said that I might have missed this info, but just how the data get into the database.
Can you still see my screen here?
Yes.
Yeah. So I'll just pull up the slide from the beginning on some of the sources and where they come from. So the data is sort of a mix of lots of different components that go into modeling. So it pulls data from published studies. This was the example I gave for the congenital heart disease. So it pulls whatever abstracts and published literature is out there. So similar to the ones that we quote and are familiar with for GBD, for CHD prevalence. And then it also pulls in the administrative records, as we just talked about, with some of the hospital data, insurance claims, and then it also incorporates in registry data if there is registry data available, and if the GBD has access to that registry data. So this is sort of a list of all that data that gets pulled in, and then
right here,
read into more of a.
Sorry.
That's okay. Yeah. So this is how you know, in the physical process of pulling the data into the GBD database, I don't know if I can speak to the logistic part of that, but basically it's pulling the data that they have for countries, especially the raw data, and then incorporating in a lot of these other factors, and then coming up with estimates based on a lot of calculations and modeling as well. And I mentioned the example of the cause of death ensemble modeling, which is a tool that's beyond my complete understanding, but I tried to explain it the best way I could, which is, you know, creating models to use covariates to create the cause of death in an area when you don't have any data in that area. So there's a lot of places where there are calculations and modeling done to create those estimates as well. Hopefully that helps explain some of that.
Yeah, I think you explained very well. So I think we just go to 9 o'clock. So, and I think that, just to summarize, I think this show the need that we have to have worldwide collaboration to get good data and to be able to provide the care that we need to provide to these growing populations, both in pediatrics and adults. So thank you, Meghan, for joining us today and for this great and amazing talk and sharing with us the source of data and this fantastic work that the GBD is doing. And I really wanted you to present this here because I think it's something that not everyone is aware of. And I think it's a great initiative that can help us a lot to predict or to model what we need for this population in worldwide. So, yeah. And for the people that joined today, thank you for joining us again and another Friday, and we will see you in the next session, which is in 2 weeks' time. And good morning, good afternoon, or good evening, wherever you are in the world. So thank you very much, Meghan.
Thank you, guys. Thanks for having me. Bye.
Bye.